us in webinar number 157 since the Andean Health Organization, Hipólito Unanue Agreement, has started a cycle of webinars in May 2020. This new year, 2023, we will continue sharing these spaces of interlearning with the best information available and, as always, based on evidence. As a reference in health in the region, we continue uninterruptedly the joint and coordinated actions with the 6 member countries, Bolivia, Colombia, Chile, Ecuador, Peru, and Venezuela, thus fulfilling the goals and objectives to strengthen the health of our people. As a reference of health, we highlight a message for the critical epidemiological situation of the region to intensify the regular vaccines and COVID-19 vaccines, remembering that protection of vaccines against COVID-19 is renewed with booster doses, and the priority age group due to the greater vulnerability are the elderly. Therefore, it is essential to complete our vaccination schedules, and it's also important to maintain care measures, non-pharmacological care measures such as the use of masks, hand washing, and isolation of people with respiratory symptoms. Remember that in places where there is a higher concentration of people, the risk of contracting COVID-19 increases. Therefore, ventilated spaces and use masks all the time remain in closed spaces. It is important to remember respect and solidarity for people. In agreement with what has been said, today, Thursday, January 25, we open our virtual door to discuss a topic of great importance for our region with the webinar number 157, Depression in Pregnancy and Postpartum, the mental health of 2 generations at stake. We invite you to leave your name, organization, and country in the comment box of the Facebook Live or YouTube live chat. In the same space, you can leave your questions or send them via email to webinarhorasconju@gmail.com. To access the certificate of attendance, as usual, in any of the Facebook Live or YouTube live chats, you will find a fixed link. You must fill out a short survey and then leave your data for the issuance of the certificate. And it will be sent in the coming days to your emails. To start this important day, I give the floor to Dr. Maria del Carmen Calle Dávila, Executive Secretary of the Andean Health Organization, who will give the welcome and institutional greeting. Go ahead, Dr. Calle. Thank you, Marisela. Webinar number 157. And the topic is Depression in Pregnancy and Postpartum, the mental health of 2 generations at stake. This month, we're celebrating the International Day of Depression, and we are also fully convinced of the approach in the course of life. And definitely the famous mother-child team is extremely important for the generation of different disorders, and we need to talk about and consider mental health. We know that depressive disorders and post-anxiety disorders are the 2nd and 4th leading cause of years lived with disability, respectively, and suicide mortality, which increased by 70% between 2000 and 2019 in the region, claiming almost 100,000 lives per year. In addition, we also know that during the pandemic, one of the populations with highest vulnerability have been pregnant women, and we have observed an increase in depression in pregnant women. Some data from Latin America are telling us of 26 to 29, increase to 26 to 29%. But we're not only talking about mothers who had COVID, but the fact of being afraid of being infected and the fact of transmitting COVID to their children has also increased the possibility of developing anxiety and depressive disorders. On the other hand, we know very well that there is a mental health treatment gap. If we talk about mental health treatment in our region, we're talking about 90%. This is in the Latin American region. If we are talking about the Andean region, our 6 countries have a different degree of development in terms of access to mental health. There are 2 countries that manage community mental health. I'm talking about Chile and Peru. And the fact of having this type of model has also contributed to the decrease of this lack of access to mental health. However, the pandemic has changed everything. And there's been months in which there has not only been a drop in diagnosis of mental health, mental disorders, but also people have not been treated who have mental health disorders. And the studies showed us, and there's a study carried out by Cayetano and UNICEF that talks about the percentage of risks for mental health in children from 0 to 17 years of age. We're talking about 1 out of 3. Mostly the risk for depression and anxiety. On the other hand, we are the country that has the largest number of orphans due to the pandemic. When we talk about orphans, we are talking about the loss of one of the 2 parents, of a grandparent or both grandparents, of a caregiver, and in amazing cases, the loss of parents, caregivers, and grandparents. So there is a large group of children who are going to require special interventions in maybe improve or mitigate. I don't know the exact words to use. Now, mental health should be considered as an absolute important part of health. The motto of there's no health without mental health becomes extremely important in this post-pandemic era, because we very well know that due to different factors, and we're not only talking about long COVID or sequelae, we're talking also of mourning, emotional disorders, and everything that is happening and has not yet been investigated, although the 5th wave in Peru has apparently it's apparently over. We have not yet declared that the pandemic is over. The mental health conditions are definitely an important cause of morbid mortality and disability in the Americas. and
definitivamente no en el futuro. Ya
not in the
hemos
future. At this
más que
moment,
incrementado,
there's been an
digamos, la demanda de
increase
servicios.
of service
No
demand.
podemos dejar de lado
We cannot
todo lo que
forget
significa,
everything that
digamos, el
means
tema de hoy día,
today's topic that
mayoritariamente
is
el
a
tema de
priority,
depresión.
and we're going to speak about an
Y es
important topic that
importante
is depression.
que
And it is
se
important
reconozca
that we
que la gestación
recognize
es un
that
periodo de
gestation
mayor
is a period
vulnerabilidad
of higher
a
vulnerability for the diagnosis
depresión
of depression.
y se tome las medidas
And we can take the
pertinentes,
necessary measures
porque
so
la
that we can take the
depresión
necessary measures
sola, con las
because
medidas pertinentes,
depressions with
puede
adequate
empeorar.
measures may improve.
También los números son muy claros
The numbers are
que la
also quite
identificación
clear. There's been
de
an increase
suicidios,
in the rate of
la tasa
suicide,
de suicidio se ha
and the rate of
presentado mayor.
suicide has
Obviamente
been
nosotros sabemos que el
greater
suicidio no se
because
presenta
we
en
know
personas
that
mayores,
when we
se presenta en jóvenes.
that
Pero
we
en esta
the
mayor
suicide is
incidencia
present
es
in
el
the
incremento
elderly
en
or young
jóvenes.
adults, but we've seen here during the
Eh,
pandemic an increase in the
depresión
young
es
population.
una enfermedad
Depression is a
y
disease,
yo creo que eso es un
and
tema
I think that
que a mí me
this is
encantó en
something
una
that I
entrevista que le hicieron
really
a Marta hace unos años
enjoy the
en Foro
interview
Económico,
that they
donde
did
ella
on
fue muy
Marta,
contundente, ¿no?
and
Porque
you were
dijeron
very clear by
que la
saying, well,
depresión, ¿no? Quisieron
they
como
wanted
decir, ay,
to
bueno, uno está
say,
deprimido,
well,
no, la
you're
depresión
depressed
es
and that's
una
no big deal.
enfermedad
No, and you
que
mentioned that
necesita
depression is a disease
tratamiento
and
farmacológico
it
en la
requires
mayoría de los casos
pharmacological
y
treatment in
una
most
seria
cases
forma de apoyo
and a
psicológico, psicoafectivo,
psychological
pero eso ya nos lo
support
contará
platform.
Marta.
I don't know, maybe Marta could
Yo
expand on
quisiera
that.
que también
It is also
reconocer a
important
las
to
mujeres en
recognize
especial, no
women
solo en el periodo de
not
gestación,
only during the
pero de una
gestation
manera
period,
prioritaria
but as a
en el
priority
periodo
in the
postparto,
postpartum
¿no? Y cómo
period,
esto
and
va
how
a afectar
this is going
esta
to affect
relación, este vínculo,
this
este apego
link,
seguro que tiene que
this safe
construirse
attachment
en
that
los
needs to be
primeros
built
meses de
in the
vida de
first
un
month
niño
of
o
life
de
of
una
the
niña.
child.
Eh, Estamos muy contentos y
We
tenemos
are
el
very
privilegio
happy and we have
de
the
contar en
privilege
este
of
webinar
having
con
us
una magnífica
having
profesional
this
del
webinar
tema,
a
quien
professional,
con
outstanding
brillante
professionalist topic
conocimiento y
who will share
experiencia
her knowledge
en
and
el tema,
experience
destacando la situación
by
y los desafíos
talking
para
about the
atender en
challenges
la salud mental
to
con calidad
achieve a good
de
quality of
una
mental health care
forma
that is timely and
sostenible
adequate in our
que
countries,
contribuirá
that will
a
contribute
disminuir las
to decrease
desigualdades
the
en la salud
inequalities
mental
in
en
mental
más de
health of the more than
168 millones de
168
habitantes
million
de esta
inhabitants
región.
that the region, that the
Nuevamente,
Andean region has.
muchísimas gracias
Once
Marta por
again,
estar con
Marta,
nosotros.
for being with us,
Bienvenidos,
and
bienvenidas
welcome
a este
to
webinar
this
número
webinar
157.
number 157. Thank you.
Gracias, doctora Calle.
Thank you, Dr.
Luego del
Kaye.
saludo de nuestra
After the
executive
greeting of
secretary,
our
la
executive secretary, introduce
Marisela
myself. My name is
Montesorio,
Marisela
secretaria
Montessori.
adjunta
I'm
del
the
Organismo Andino de
Deputy
Salud,
Secretary of the Annual Health
y
Organization, Nepal Union
hoy día
Agreement.
con
And
mucho gusto
today,
estaré a cargo de la
I am
moderación de este webinar.
gladly being charged of the moderation of this webinar.
Luego de este preámbulo,
After this
vamos a
preamble,
darle la
we
bienvenida a la
welcome
doctora Marta Rondón,
Dr. Marta Rondon,
médica psiquiatra con estudios de
psychiatrist with
pregrado en
undergraduate
psicología de la
studies in
Universidad Nacional
medicine at the
en Arequipa.
National University of San Agustin,
Posteriormente
Argentina,
obtuvo
with a
su
degree of
licenciatura
specialist in
en Educación
psychiatry
Peruana,
from the Peruvian University Cayetano
realizó un
Heredia,
máster en
a
políticas
master's degree
psiquiátricas
in
y
mental health
comunitarias
policies and
en la
services from the
Universidad
Universidad
Federal
Nova
de Lisboa,
from Lisbon,
Portugal.
Portugal.
Consultora en
She's a
psiquiatría
consultant
en el
in
Instituto
psychiatry in
Nacional
the
Materno Perinatal en
Perinatal
Lima.
Mother and Child
Anteriormente profesora
National
asociada
Institute
en
in
la
Lima, formerly
Universidad
assistant professor at
Nacional,
the Peruvian University
actualmente
Cayetano Heredia,
dedicada
currently visiting
a la
professor
Educación Nacional
of the National
Federico Villarreal
University
en
of
la Escuela
Federico
San
Villarreal,
Martín de Porres
San Martín de
y
Porres Private
Universidad
University,
Mayor de San Marcos.
and San Marcos National
Es
University.
vicedecana del Colegio
Former
Médico
Vice
del
Dean of the
Perú
Peruvian
y diplomada
Medical
en Derecho del
Association in
Trabajo. Ha
2008-2009.
recibido el diploma al
She
mérito
received
de
the
esta
Diploma of
institución
Merit from this
en el
institution in
2007 y el
2007
diploma
and the
y
Diploma
medalla
and
de
Medal
mérito
of
extraordinario en octubre del
Extraordinary
2015.
Merit in October
También
2015.
ha sido expresidenta
She's former past president of the International Association of Women's Mental Health and honorary member of the World Psychiatric Association since 2005. Former president of the Peruvian Psychiatric Association from 2004 and 2005, and member of the expert committee in sexual and reproductive health of the Ministry of Health in Peru. She's a researcher in women's mental health, gender-based violence, emotional consequences of induced abortion, rights of women and people with psychiatric disorders, and mental health services. She has presented more than 200 lectures nationally and internationally on gender issues, human rights, and the right to health, gender-based violence, and integration of mental health care. Dear Dr. Rondon, thank you very much for accepting the invitation to share your time with us and your experience. Go ahead, you have the floor.
Doctora, tiene el micrófono cerrado, por favor.
You need to activate your microphone, Dr. Rondon.
Estamos viendo la presentación, pero hay que ponerla en pantalla completa también, por favor. Se ve perfecto.
That's fine.
Ahora no le escuchamos, por favor.
We can't hear you. You need to open your microphone and mute your microphone, please.
Ok, ahora sí. Muy buenos días.
Good morning. Thank you so much for your words, Dr. Mari Carmen,
Mucho cariño, mucha admiración y mucho respeto
for
por
which
su
much
labor.
admiration because of your work and
En
efforts.
general, muy
And in
comprometido
general, I am very pleased
poder hablar de este tema
to
que a mí
talk
me
about
apasiona.
this topic that passions,
Eso
my
es
passion,
la
which is pregnancy,
perinatal.
the perinatal time.
Quiero decir que no tengo
I
ningún
will say I don't have any disclosures.
y que en esta presentación
And
vamos
during my
a
presentation, we're
¿a
going
qué se
to
refiere
define what do we mean by perinatal,
solemos
which
usar?
is the term that you
¿Cuál es la
use,
magnitud de este
what is the
problema?
magnitude of this
¿Cuáles son
problem,
los factores de
what
riesgo?
are the risk and
¿Dónde se
protection
presuponen ser los
factors,
factores
and
que
on which
podemos
of these factors we may
¿Cuáles
act
son las
upon,
consecuencias
what are the
para la salud de la madre
consequences
y el
on the
producto?
mothers
¿Cómo
and
se maneja
product
y
health,
las conclusiones
how we manage
y
it, and some
recomendaciones?
conclusions and recommendations.
Los objetivos serán definir la
The goals are to
presentación
define the presentation and treatment of depression in pregnancy and
y los
postpartum,
riesgos y beneficios
define the risk and benefit of the use of psychodrugs, and to describe and evaluate the vulnerability of women
en el
who
periodo
presents a
neonatal
mental disorder during the
y finalmente
perinatal period,
intervenciones para
and to
prevenir
describe
la
an intervention to prevent the consequences
enfermedad
of
materna
maternal
sobre el
mental health
bebé.
disorders on the child.
El periodo perinatal
The perinatal
es
period
al año
has to do to
después del parto
the year
y
after
a todo lo
the
que puede
delivery
suceder
and
durante
everything
los
that can
primeros
happen during
meses
the
del embarazo.
pregnancy from the start of pregnancy.
Cuando uno habla de
When we
depresión
talk about
postparto,
postpartum
según
depression,
la clasificación
according to the North American classification of
habla
DSM-5,
de
it
hasta
indicates
14
that it
semanas del
up to
parto.
4 months, 5 weeks after
Esta es una
delivery.
definición que los
This
médicos
is a definition that the Americans themselves
controversial
find
y en
very
general
controversial, and in general in psychiatry,
perinatal
we
durante
talk
todo
about
el embarazo
perinatal during
y
the
durante
entire
todo el
pregnancy
año
and during the
precedente
year,
al parto.
entire year after
¿Y
delivery.
por qué nos enfocamos
Why
específicamente
do we focus
en el periodo
specifically
perinatal?
in the perinatal period? Is
Como ustedes
because,
pueden ver en la
as you can
presentación,
see in your graph,
admisiones
the
psiquiátricas
psychiatric admissions
van
increase
alrededor del
significantly
parto.
around the
Después del
delivery.
parto hay un pico
In the
muy
postpartum,
grande
there's a
y
large
este
peak,
tiende a
and this
disminuir
tends to
hacia
decrease towards
se
the
completa el primer año
end of the first year of life of the child.
En psiquiatría
So
es
in
referido
psychiatry,
alrededor
this
del
period
nacimiento, un
around birth,
año antes y un
1 year
año
before and
después,
1 year
es
after,
extremadamente
is
importante.
extremely important
Uno de nuestros indicadores
because one
de
of our
reproducción
strong indicators, which is the need for
incrementa
hospitalization, increases
significativamente. Y entonces
significantly.
eso nos obliga a
So that
mirar
forces us
qué es
to
lo que ocurre,
consider what
cómo es
happens,
que en realidad
how
es
is
cierto
that it
que
is
el
not
embarazo
true
te proteja de la
that
depresión,
pregnancy protects
porque la
against
estás en ese
depression
momento,
because you're so happy at that
o
moment.
lo que decían los antiguos
And what
filósofos
the
de
old
que las
people said
enfermedades mentales de las
that
mujeres
women's mental
nada más
diseases
llegan
were
al
solved
marido
by
y tengan un
getting
bebé
them with a husband and
es
have a child
completamente
is
falso.
absolutely false.
La prevalencia de los
The
trastornos
prevalence
mentales
of
está
mental
relacionado
disorders is
con
in relation
las condiciones
to the
socioeconómicas.
socioeconomic
Y es muy
conditions.
importante
And it's very
conocer
important
cómo
to
siguen más o
remember
menos la
how it
distribución marcada por
follows
el Banco
the
Mundial respecto de
approximately
cuáles son los
distribution
países
of the
más
World Bank of
desarrollados y los
high-income
países
countries
medianos y bajos
and the lower and middle income
Entonces, en los
or
países de altos
mid-income.
ingresos,
The countries of
tenemos
high income,
países
we
algunos
consider that 10
donde
to
las mujeres
15% of
pueden
women
tener algún
are
tipo de
going to show
alteración,
some type
ya
of
sea
disorder,
en el embarazo
either during
o en el
pregnancy
posparto.
or in the
Y
postpartum.
desde más o menos
And
2004
from
tenemos un
2004,
acuerdo en el
we
mundo
have
de que
an
las
agreement in
tasas
the
de
world that
depresión
the
prenatal
figures for
son
prenatal
más bajas
depression
que las de
are
depresión
higher
puerperal.
than those of postpartum
Aunque la
depression,
depresión puerperal se
although
conoce desde la época de
postpartum
Hipócrates,
depression has been
la
recognized
depresión
since
prenatal
Hippocrates,
es
and
mucho
prenatal
más
depression
reciente.
much more recent in its
La verdad es
description.
que hay más
The
depresión
truth is that there
en
is
el
more
posparto.
depression during
Esta
pregnancy,
depresión en el
and
embarazo es
this
un
depression
factor
during pregnancy
muy
is a
importante
very
para
important
la
predictive
depresión en el
factor
posparto.
for
Por
postpartum
supuesto que
depression.
cuando la mujer está
Of
deprimida
course, that
en
when
el
the woman
posparto,
is depressed in the
siempre
postpartum,
dos personas,
two people are
ella
affected,
y el recién
she
nacido.
and the newborn.
De una manera más visible,
In a more
lo que se
visible
afecta
way
durante el
of what
periodo
is being
prenatal es
affected during the
depresión, pero
prenatal
también hay
period,
consecuencias
because in the
para
prenatal
el feto.
period there are also consequences
En nuestros
for the
países,
fetus.
depresión
In our
prenatal
countries,
representa
prenatal
una de
depression,
cada cuatro
1 out of
mujeres,
4 women,
25%, un poquito
25%,
menos, con un intervalo de
with
confianza
a confidence
superior al
interval that is
90%,
not
porque nos
wide.
damos cuenta
So we
que es
realize that this
más o
figure
menos
is more or less
confiable, ¿verdad?
reliable.
Esto hace lo que quiere. En el posparto,
In the
la
postpartum
prevalencia
period,
es cercana a
the prevalence
20%.
is close to
Una de cada
20%.
cuatro
1 out of
mujeres,
4 women,
19.7, una de cada
one
cinco
out of
mujeres,
fifth, 5 women,
19.7%, y nuevamente con un
19.7,
intervalo
and
de
once again,
confianza
with a
estrecho.
confidence interval that's quite
Estas
narrow.
cifras vienen de un
These
trabajo
figures come
realizado
from a
por la
study we did
doctora Gelaye de
by Dr.
la Universidad de
Gelaye
Harvard
from the
Escuela
from
de
the
Salud Pública,
Public Health School of
y
Harvard University,
recogió alrededor de
who collected
57
approximately
trabajos de todos los países de
57
medianos y bajos ingresos,
projects from
en
low and
donde
mid-income countries
hubo una
where
población
they
eh,
had a
consolidada de cerca de
consolidated
400.000
population
casos,
of almost
con una
400,000
población
cases.
más o
So
menos
these are
confiable.
more or
Hay
less
otro
reliable
estudio que nos
figures.
habla de
There's
que
another
en los países directamente
study that
pobres,
shows
los
that
más
in the poor
rojos,
country, the ones in red in
el
the map that you
deterioro
can see,
puerperal sería alrededor del
postpartum depression will be
25%,
close
es
to
un poquito más
25%,
alta.
even
Y hay que
higher.
recordar
And we need
que
to remember
nosotros hemos estado
that
conmocionados en todo
we've
el
been
mundo
shocked
con
throughout the world
la pandemia por
with the
COVID-19,
COVID-19
y hemos
pandemic,
tenido un
and that
incremento
has resulted in
de
an increase
las cifras tanto de
of the
ansiedad
numbers,
y
both in terms
depresión
of
en el periodo
anxiety as well as
prenatal
depression in the
como de
prenatal period,
dificultades en
and
el
also
posparto,
difficulties during the
por las
postpartum period
preocupaciones, las
due to
preocupaciones, el
the
estrés que
conditions, the
convive
stress,
con
the
una
concern
infección
of
entre
living
nosotros, las consideraciones que
with an
afectan en
infection
salud
among us and
pública.
everything else that Dr. Kaya has mentioned.
Las mujeres
In
tienen
Africa,
tasas
women
altísimas
have
de
extremely
HIV.
high rates of
En
HIV,
general, se
and in
vienen a
general,
enterar que
they've
tienen
learned that
esta
they
enfermedad
have this disease
cuando entran a la atención
when they go to prenatal care or come for delivery. So these conditions that their mental health is even more affected, and therefore it will be one of the explanations why they have such high rates of depression in the prenatal period as well as the postpartum period in this part of the world, with the exception of South Africa that has living conditions that are similar to other countries of better income. So, what are the risk factors? What are the factors that condition risk? This can be divided, according to Dr. Freeman, in those who have a high risk, a high chance of predicting depression, and those who have a lower risk. So it's a lower probability that a woman that shows this condition will present with depression. And the highest risk is the personal history of depression. So a person who had a depression at any time in their life, and remember that now we see depression in girls and boys, has the highest risk. Also, a depression in a previous pregnancy and anxiety during the gestation or in the previous gestation. The presence of a stressing viral event. We used to say in the last 12 months, but more and more we realize that it's a stressing viral event and early, before the age of 18 or in the last 12 months. This, what happens during the first 18 years has to do with everything that we've learned about the early adverse events that we know that are related to non-transmissible chronic diseases and are also related with depression, anxiety, and the emergence, the premature emergence of severe diseases such as schizophrenia and bipolar disorder. And these viral events that are stressing are very important to consider, and we have among them the exposure to violence, especially sexual violence under the age of 18, and death of one of their partner or parent. There we need to think in the COVID-19 orphans, how this that occurred in 2020 is going to have some important correlation with mental health in 2040. Another stressors are the couples conflict, the stress of taking care of small children, the inadequate social support, and having to be dealing with a newborn that has difficult temper is also an important factor for postpartum depression. A lower risk, but still a risk, is the unplanned pregnancy, the low socioeconomic status, and by not having a couple, either because a woman is single or because she was abandoned when the pregnancy was apparent, as we see in women in our region. The prior history is extremely important. It's not only important to see the history of adverse events in the first 18 years of life, but in particular, the psychiatric diseases, and among these, the affection diseases. Depression during pregnancy will predict depression postpartum. And if we find a woman who is depressed during the 9 months of pregnancy, this woman is going to have a higher chance of presenting depression after delivery. This is extremely important because if we realize of a woman who has a history of depression sometime in their life, and We forget about the new things about the new, of how we know now to treat pregnancy depression, and we don't treat the depression during pregnancy that can be presented in the first trimester. We are putting her at risk of leading to postpartum depression. And what is important to remember in the public health systems that we have the pregnant women in our watch during prenatal control, but after the delivery, there's only has one control, and she's free. And, it's, and then the newborn starts to come into place, but the mother, we stop looking at the mother, and there is where there is a higher risk for mental health. Now, if the woman had postpartum depression before or puerperal psychosis, she has 50 to 70% of relapse, at least depression. Puerperal psychosis is extremely rare, 1 out of 1,000. But if a woman with postpartum depression has a second pregnancy, she has a 50% chance of presenting puerperal psychosis. A history of bipolar disorder is going to give us 30 to 50% of risk of postpartum psychiatric disease. And this may be depression or maniac, and it's difficult to treat. So women with bipolar disorder can get pregnant, of course. There has to be preconception treatment. We need to look at time of her life where she's stable, and we need to forget the horror of drug therapy during pregnancy to decrease the risk of severe psychiatric disease in the postpartum. And then we have women with a history of recurrent depression, that we see them more and more because they had difficult childhood or adolescence. They got depressed and they were not treated. And when you don't have this treatment, this tends to become chronic, and they present several episodes before getting pregnant. These patients have a 30% risk of postpartum depression and have to be observed very carefully during pregnancy because there is also a risk. It's lower, but still a risk of depression and during pregnancy. What is the role of hormones? We would like to say that large changes in hormones during pregnancy and postpartum are responsible of postpartum depression. But we see that all women who have children go through these changes in the hormones, a massive hormone tides that have psychoactive effects. So the brain perhaps has 200 times more estrogens than before, and then it drops 7 days later. And that may be the reason why we see these diseases in the postpartum, but that's not true. At this moment, we cannot say that there is a specific hormonal variation of women who have postpartum psychiatric diseases. But there seems to be is a abnormal behavioral sensitivity to the change of these hormones. Some authors for several years were convinced that the recessive way of serotonin transport hormone was responsible that things occurred, because it is true that there's not proper functioning when there is a variation in the estrogen rate, but this is not a complete picture. The role of hormones is limited. Probably the thyroid problems will be more important in postpartum depression. It has been found that there is a large association between hypo or hyperthyroidism and postpartum depression. And hypothyroidism is more frequent and easy to understand, On the case of hyperthyroidism, is because of an acute thyroiditis. Women may be hyperactive, but also profoundly depressed. So in the postpartum, what we look more than estrogen and progesterone, we study thyroid. In some areas, they've given the portion of corticotropin releasing hormone had received importance, but now we know that this is more related to depression that has to do to the one induced by a previous exposure to trauma. What are the protection factors? Planned parenthood or pregnancies, regular contact with health service during pregnancy that will allow us to detect changes in the well-being in order to act, that will allow us to reassure women that things are going well, solve their concerns, uncertainties, and to provide a warm and protective institutional environment that they feel protected. The health services exist so that we can offer well-being to our users. Health service has not to be focused in comfort and well-being and tasks of the health staff, but instead they need to focus in the well-being of the people we care. So this regular contact with a friendly service, we know that is a protective factor during pregnancy. Another protection factor that is outside our scope, but is extremely important, is education beyond high school. We know that elementary education doesn't protect anyone. By having just primary or elementary education, our country is related with more couples violence than not having education at all. So we need to fight so that the women can have education beyond high school, social support during pregnancy, and when having their babies is a shield against postpartum diseases. It's been promoted that in postpartum diseases occur less frequently in rural areas and more conservative areas where the rituals are of postpartum confinement are still maintained. 40 days with the sisters and sisters-in-law taking care of you. That is a major help and protection for women. And this makes us to question how mental health is doing in women that need to go back to work 8 years after delivery. And the other thing that we need to take care for, and it's important, is the sleeping routine in the postpartum. So for women who had a depression, especially those who had bipolar disease, we need to do whatever it takes so that women can sleep during the night and to aim to a closest sleep to 8 hours as possible. Milk extraction for giving the baby the bottle, the use of formula, recruit a husband or some family members that can take care of the child feeding during the night are all things that we need to use to guarantee sleep to the woman, especially the one that has a history of bipolar disease, because sleep deprivation challenges the obsession. And we need to take care of their sleep. It's the same way as women that may fall in depression. What are the consequences on the mother's health? There's an association described by several authors with preeclampsia. We have not found that there is a link of causality or a pathophysiology that is common, but they tend to go together. And we need to remember that preeclampsia is a cause of death. It's an important cause of death among us. So there's a reason to be alert for depression because depression is going to show before the preeclampsia. There is also an increase in obstetric complications, including the need of an emergency cesarean section. Abrupto placente, the ROP, prenatal depression is related to an increase of up to 30% of prematurity in with children that are born with low weight for gestational age, which is easy to understand because there are disorders of inflammatory pathways that will produce an early delivery. And similarly, there are alterations in the cortisol metabolism in the umbilical cord that expose the fetal brain to high levels of cortisol, but who also give rise to a relative contraction of the umbilical artery and to a decreased reach of nutrients, transfer of nutrients to the fetus. So there's low weight for gestational age, which is a very unfavorable way of being born. And suicide, which is an important consequences of depression, becomes frequent, is a frequent cause of indirect maternal death. The numbers vary a lot from 0% in South Africa up to 23% as it has been reported in Argentina. This study published in Lancet Psychiatry that compared the death of pregnant women by injuries and suicide that were demonstrated. And it tells us that these figures are perhaps false because there's a lot of stigma with suicide and therefore it's not recorded. In any case, Europe and the region of the Americas are the ones who have the largest number of maternal death due to suicide. And we know that in Peru, in 2014, 50% of maternal death in teenage pregnancies were by suicide. And we constantly have cases of pregnant women who commit suicide. We should not be surprised that we have a significant number of suicides in pregnant women because suicidal ideation in women is extremely high. In the PROMIS cohort that followed in the maternity hospital, there are approximately 5,000 women that were included in the study when they were 26 to 28 weeks of pregnancy, and we are following them during the course of pregnancy, delivery, postpartum, and now we are following their children, and some of them are 5 or 6 years old. We have found that 22% had 22.6% had suicide ideation when they were interviewed, and 22.4% tell us that at some point in their life they had suicide ideation. 22%, this is a large number. Suicide plans in 7% of these women, and 6% show suicide attempts at some point in their life. But they failed. That's why they're not dead. These figures tell us of a high exposure to important stressors in the early stages of life that influence in a high level of impulse that has to do with ideation or suicide ideation or behavior. They talk about high rates of depression, but they also make us look that there are women who are not depressed, who have suicide ideas, And that is very important to
Pero sobre
study
todo, miren
more.
ustedes,
But as you
cuando
can
hay
see,
plan suicida,
when there is a suicide plan,
es muy probable que
it's very
aparezca el
likely
intento suicida.
that they're
Los
going to
estudios
have a
científicos
suicide attempt.
en
7% had plans
recientemente
and 6%
dijeron el
attempts.
intento suicida. Entonces, eso es algo que tenemos que
So this is
preocuparnos
something that we need
seriamente
to ask
con nuestros
ourselves
pacientes.
with our
Ah,
patients.
tiene ganas de morir, tiene ganas de
You want to,
matarse,
you
alguien
want to
le
die,
dice,
you want
tus planes
to
de
kill
terminar con él.
yourself. Are you
Entonces,
considering that idea? What have you done in
¿qué
this
tipo de
regard?
planes tiene?
What type of plans do you have?
Vean ustedes
And you
cuál
can
es
see
la
what is
relación
the
con el maltrato
relationship
infantil.
with child
El maltrato infantil
abuse.
incrementa
Child abuse
la ideación suicida en
increases suicide
2,57
ideation in
veces.
2.57.
Quiere decir que si tú has tenido
So if
maltrato
you've had
infantil, vas a tener más del
child
doble
abuse or child
probabilidad
batter, you're
de
going to have twice the possibility of thinking in
y en tres
killing yourself,
veces la
and three
posibilidad
times the
de estar
possibility
albergando planes
to
suicidas. Es decir,
considering suicide
pensar
plans of
el pensamiento de lo que yo
start
quisiera
thinking
hacer
of what
para
would like to do
terminar,
to
hasta
end with my life,
informarme en la
to
internet, donde es tan fácil
find in
informarse,
internet
empezar a buscar el más
information
campeón, fijarme cuál es el
of
puente más
looking
alto,
what is the
bueno,
highest
es
bridge
decir, es
next to
decir,
my room, that type of information.
el intento suicida
And the
ha
suicidal
aumentado
attempt
por
increases in
tres veces
2.4
cuando ha habido
43 times
maltrato
whether
infantil,
there's been
ya sea
child
físico
abuse,
o
either
sexual,
physical,
pero
sexual,
maltrato sexual un
but
poquito más,
sexual
eh, el OR de
abuse
ideación suicida es
and the
bastante alto.
OR for suicidal
Entonces,
ideation is
nuevamente
4.
vemos
So
cómo
once again,
ocurre
we see
el
that what
nacimiento de
happens
una
during
persona
infancy and
hasta que
adolescence
muere
is very important
cómo va a
to
ir
see
el
how
embarazo.
pregnancy is going to
Ahora,
perform.
los efectos negativos
Now, the
sobre los
negative effects
hijos
on the health
tienen
of the
que
offspring has to do
que se forma un vínculo inseguro,
of an insecure
habrá
link.
problemas de
There's going to be
conducta,
behavioral
va a haber
issues.
alteraciones
There's
en
going
el
to be
comportamiento
impairment in
cognitivo,
cognitive
porque hay
function
menos estimulación
because there's less stimulation
incorrecta
or an
y
incorrect
el vínculo
stimulation,
inseguro no
and
genera
the insecure link
felicidad.
doesn't uh,
Esto ha
teaches us
incrementado de sufrir
there's an
neglect.
increased risk of having
Hay un
neglect,
mayor número de síntomas
and
de
there's a higher number of
discapacidad en la infancia.
symptoms
En
and
los niños que
signs
necesitan
of
cuidados
mental
intensivos
disorders in childhood,
postparto,
of
y hay
women
una
who have
falta de
postpartum
cumplimiento
depression.
de
There's a lack of
esquemas de
compliance
control de niños
with
sanos,
the
por
schedules for healthy child and vaccination,
esto es
which
muy
has a direct
responsable de la
correlation on morbid
mortalidad
mortality
infantil.
of the child.
Nuevamente, el
Once
impacto
again, the
es
impact
diferente
is
en
different
países,
and
según si es
higher
un
if,
país de altos
if this
ingresos
is
o
a country of
un
low
país
income or a
de
country with high
bajos
income.
ingresos. Nuevamente, el mapita del
Once
mapa
again, the
donde
world
ustedes
map,
pueden ver
you
que
can
en
see
países
that
de
in
altos ingresos,
high income countries,
¿no? Acá los tenemos,
here we have them,
em, hay un trastorno cognitivo que tiene
there's
que
a
ver con la
cognitive
falta de
disorder that has
estímulo,
to do with a lack of
también el
stimulation.
aumento de los
There's a
trastornos
risk of
mentales,
increase of mental
hay una serie
disorders.
de vínculos inseguros
There's an
y hay
insecure
un
link
incremento
or
del riesgo de
attachment, and there's
maltrato
an
infantil.
increase for child
En
abuse.
nuestros países hay todo
In
esto,
our countries, we have all of that,
pero
of course,
además
but in
hay un
addition,
aumento de la
there's an
mortalidad
increase
infantil
of
en
child
cuanto
mortality
a el retraso de la lactancia y
and
los planes, los esquemas de vacunación
the
incompletos.
complete
Hay más
vaccination
efectos
schedule and breastfeeding.
con el retardo
There's
de la
higher
lactancia y
malnutrition
enfermedades
and a
diarreicas
large number of diarrheal and respiratory diseases,
que tienen que ver
and more
con
diseases that have
la
to do
disminución de la inmunidad
with a
a
decrease of
altas
immunity because of high
diarreicas
exposure to
y
diarrheal
respiratorias
diseases and respiratory
durante el
diseases
primer año
during the first
de
year of
nacimiento.
life.
Se compromete el estado
So
emocional
the
de estos
emotional
niños
state
de
is
bajos ingresos. Se compromete la
compromised in these
conducta y
children
también
of high
la
income countries,
capacidad
and in low
de
and medium income countries. Not
desarrollo
only that,
de
but
base.
the survival chances.
¿Cuál es la relación
So what is the relationship
entre el vínculo y la
between
psicopatología?
the attachment or link and
La
psychopathology?
regulación del
The
afecto
regulation of
que hace la mamá.
affection
La mamá es la que regula
by the
las
mother who
necesidades,
regulates the
regula el
attachment,
afecto del niño.
regulates this
Sus
attachment,
interacciones con
and
el
their
recién nacido
interactions with the
hacen
newborn
que éste
make
establezca
that
un
they
sexo
establish a
afectivo
preferential link with the mother.
de más seguro.
feels more
El
secure.
vínculo preferencial
This preferential
tal vez más
link
cómodo, más
or
protegido,
attachment where the child feels
esta
more
figura
comfortable, more
puede
secure
proporcionar su afecto e
with this
interacción
figure that
tierna
can
y
interact
caliente
with
y
warmth and care,
proporciona un contexto
provides a
para que pueda
context
organizar
to organize
su cerebro
eh,
y en
his or
consecuencia
her
su
brain and
conducta.
therefore their
A
behavior.
este
A
a
child
quien le podemos regular el
who we
afecto
can regulate this
efectivamente exitosamente.
attachment in
Los
a
primeros
successful
días y
way
semanas de la vida
in the
es
first
un
years
child
of
en
life is
general
going to be a child that in
feliz,
general is
va a
going to
dormir a
be
las
happy,
horas, cuando se
sleep,
despierta va a estar jugando,
be
explorando su
calm when
mundo,
they
no haciendo nada.
are awake, is going to be playing.
Las interacciones entre la madre y el
The
niño
interaction between the mother and child
del vínculo
before strengthening that link
le van dando forma a la regulación
shape
fisiológica
the
del niño.
physiological regulation and response
Me
pattern.
muevo, bien. Entonces yo tengo que
So
moverme,
I have
sentir
to
un
move
poquito,
and cry just
diferente
a
de
little to be
no
taken care of, as opposed
lloro,
to the child who
eh,
has to be moving
lloro un
and
poco,
is crying and there's no response,
grita.
so they start crying louder.
Entonces tengo que llorar más
So I need
para mantener
so I
una
need to
comunicación con esta persona.
maintain a communication. I have to
El
cry
vínculo
louder.
seguro,
The safe link
el, el que demuestra que
that
es
shows
para mí,
the safe attachment
permite que el
allows
infante
that
pueda
the
explorar
child
su
may
entorno en tiempos de
explore
ternura.
the environment from a
Es
safe
decir, que va a estar
place.
más despierto,
So it
más
will be
alerta,
more awake,
más
more alert,
autoconfianza en lo que
more
necesita
outgoing,
y le permite integrar
and
lo
allows
que ha
them to integrate their
aprendido
neurobiological, cognitive,
de una
affective, and
manera
conductual
armoniosa,
capacities
aún
in a more
reconociendo que cada uno
harmonized way,
es acomodado.
recognizing that each one develops at a different rate.
El maltrato infantil, cuando esta
Child
relación
abuse, one, if it happens when
confunde
there's attachment is being
la
established,
figura
it creates
vincular
confusion.
es al mismo tiempo la
The
figura
attachment figure is at the same
segura.
time the feared figure.
Eh, el niño no se
So the
siente
child
seguro
doesn't feel
preguntando lo que
safe
necesita,
in asking what they
explorar,
need and to
porque no sabe
explore
cómo va a
because they
responder
know how
la persona con
this
otra edad
person
mayor
is
que él.
going to respond.
Aumenta el riesgo de
There's an
desarrollar
increase of
patología
risk of showing
porque no le
symptoms
permite
because it
reaccionar de
doesn't
manera
allow
adecuada al
to
estrés.
react
Va a
adequately to
reaccionar siempre
stress.
con
There's
mucha
always going
ansiedad.
to be a reaction with high
Esta
anxiety,
ansiedad va a producir
and this
norepinefrina,
anxiety is
que
going to
va a ir
trigger
al
norepinephrine that's
lóbulo
going to
frontal
go
y
to the
frontal o
prefrontal and frontal
cortexal
lobe
que
that
todavía
is
no tiene
that's
desarrollado.
being
Entonces,
under
va
formation,
a
and there's going to be an
desencadenar
impairment of cognitive function,
de
but also going to put them at risk
de
of having behavioral
neurodegeneración
disorders
y depresión.
and harboring
Hay
anxiety and
evidencia
depression. There's current evidence
específica entre
of a
maltrato
clear
y
relationship
psicopatología,
between
pero
abuse
solamente
and
vamos a tratar
psychopathology, but these are cross-sectional studies.
una persona ahora y hacemos el corte y vemos lo que se
And we
necesita
study
es
what we
realmente
need
demostrar y ver
to
los mecanismos.
demonstrate and
Son
look at the
estudios
mechanism
longitudinales
are
que
longitudinal
nos permiten
studies
asegurar
that
la
will allow
causalidad
us to
de esta asociación.
study
Pero
the
son
causality of this
interesantes
association.
como por ejemplo
This
las
longitudinal study
etapas
that
de
I
la
want we're trying to do
adolescencia
in the
o
maternity hospital
de
following
el
this
tiempo
long-term
donde
cohort. And we
estamos
have another study
regular el afecto,
where we are
un poco
teaching
agitado,
mothers how to regulate
todo
their
eso. Entonces queremos
attachment
saber
and
cuáles son
affection,
los resultados
and we want
en
to
un
see
grupo
the
a lo
outcomes of these
largo
two
de
groups
los años.
throughout the
Este es
years.
un cuadro de Sorolla de la
This is
madre y
Sorolla
el niño.
painting about the
Para
mother and child.
refrescarnos un ratito,
Just
ya
as a
dijimos
refreshment
que
and
voy a
switch
hablar de la
gears
detección
to
de la
talk
depresión.
about detection of
En la
depression.
atención
In
prenatal
prenatal
tenemos a
care,
la mamá ahí.
we have the mother with us.
Entonces, es
So
importante
it
que en la
is
atención
important.
prenatal podamos
Prenatal
recoger la
care, we
historia,
can
incluyendo la
collect a
psiquiátrica.
complete history,
¿Por
include
qué?
psychiatric
Porque
history,
ya sabemos que
because
desde
we
épocas
know
antiguas
that in
hay
psychiatric
alto
history,
riesgo.
we have the high risk
Y
factor.
también preguntar por
And
el
also
riesgo
to
de
ask for traumatic events like
exposición a la
exposure to
violencia.
violence.
Obviamente, la
Of
exposición a la
course,
violencia
the
la tenemos
violence
que conocer cuando
exposure,
era niña
we want to know
y
when
era
she was
adolescente
a girl,
o
an
ahora,
adolescent,
si
and
hay
a
una
present,
exposición a la violencia ahora,
because if
tenemos
there's
que
a current
actuar.
violence
Y
exposure, we
también
need to act.
tenemos que acordarnos
We also
que
need to remember
mientras no haya
that although there's
una
no
exposición
apparently
explícita,
an
hay que preguntar por violencia
impairment
suicida.
of affection, we need to ask for suicide ideation because we have then these cases without depression. The detection of postpartum depression is more difficult because they're outside the system. They're not coming every month for the prenatal care. And sometimes we look at the child, but we forget to ask about the mother. On the day 2 to 10 postpartum, we have this maternal sadness. She becomes irritable, crying. She doesn't want to see the mother-in-law. But that goes away spontaneously. This is an event. This is not a disorder. This is an event that has to do with this estrogen tide and it's self-limited. Here, what we have to do to teach the family to realize that if it goes more as beyond day number 10, if it's still growing, then we may be facing a probable case of postpartum depression. What we need to use is well, baby control to look at the emotional state of the mother, and we need to train so we can start this type of conversation with the mother and being able to detect important signs of these cardinal signs of depression, sadness, lack of encouragement, lack of energy, tiredness, fatigue. Mother say I can go anymore, but a lack of interest or pleasure. So if we see any of these three, we need to be more active to detect depression. And here we can use the use of scale, the Edinburgh scale, the DHQ, which are so useful, are used throughout the world, and are very reliable. In treatment, we need to balance risk against benefit. If the woman is going to depress during the pregnancy, she'll be depressed in the postpartum. It's going to be bad for the baby. If I leave her depressed during the pregnancy, there's a risk of early delivery, obstetric complications. The child may be small for gestational age. The brain is going to space to higher quantity of cortisol. What happens if I provide treatment? There's a possibility of an unfavorable effect of the drugs. In general, this is true, but we need to see if it's a mild depression of a moderate or severe depression. If it's from mild to moderate, psychosocial interventions of low intensity are enough. Behavioral activation, which is a very easy to technique, very easy to learn, that can be carried out by professional staff or technical staff and trained volunteers at the community level. Education for the entire family and physical activity together with this. But if depression goes from moderate to severe, we need to remember that the international recommendation the use of psycho drugs in all the guides that you're going to consult with moderation of depression from moderate to severe, the ISRS, the SSRIs are the most studied and safe. Paroxetine for some time was considered to be related with cardiac malformations. Later studies and review of the previous studies, the secondary analysis, have allowed us to see that paroxetine has more cases of cardiac malformations than others that are relatively because it has been used in more women. And when you compare the rates of malformation in women who use paroxetine with the rates of the general population who is not using any drug are quite similar. We also need to consider that there is certain risk by the fact of becoming pregnant by having depression. So at present, what we know is the selective inhibitions of serotonin reuptake are the most studied, the most safe. Sertraline in particular doesn't go access to the milk, are well tolerated by the patient and must be used. The risk of using this psychodrug is small, is less than the not using it. Now we need to follow some good practice principles. Monotherapy, the minimal effective dose, and the constant monitoring of how depression is evolving, how the woman sleeps, what's the level of activity during the day. Once a child is born, we need to work with the pediatrician to see that the baby doesn't have problem because the woman is taking sertraline or fluoxetine and breastfeeding. In general, doesn't go, it's not present in the milk. If the woman is taking with antidepressive at the end of pregnancy, they will usually discontinue antidepressive to decrease the possibility of problems of neonatal maladaptation. Neonatal maladaptation that is presented to these selective inhibitors of serotonin reuptake are transient, don't require admission to the intensive care unit. It's characterized by irritability, little tachycardia, appetite decrease, and it's over. So it doesn't need to discontinue the drug in the last month, put the mother at risk of depression and coming depressed to the postpartum because they're going to increase the chances during the postpartum. In conclusion, the depression and anxiety disorders are frequent in pregnancy and postpartum, and also other diseases frequent, but today we have spoken about depression. These conditions represent a risk for the mother and the newborn. So, because they depend on some factors to which we cannot do anything, such as the psychiatric history of the mother, what we have to do is to recognize those women, identify the women who are vulnerable, who have a history of depression, or those who have a history of trauma or exposed to violence, and be more alert to the follow-up of these women to do a timely detection. We need to remember that medication is safe even during pregnancy and is effective. And in order to take care of the large number of depression during pregnancy and in the postpartum, we need to integrate mental health care to prenatal care. But I think it's already present in our practical guidelines. We're doing some progress, and also during the control of the healthy child, its growth and development, where we have the mother at least once a month and we can learn how to ask the proper questions. Thank you very much for listening. I'm here for the Q&A. Dr. Marta Rondon, thank you so much for your brilliant presentation. As you mentioned by Dr. Valle, this is a priority issue for our institution, specifically what we've talked today of a topic which postpartum and postpartum depression. You have reminded us the perinatal period from pregnancy after the year of the delivery, and the prevalence of these disorders depending on the socioeconomic conditions, which is a reflection of inequalities that we see in our countries and societies. We have seen that in high-income countries, there are some disorders 10 to 50%, but in lower-income countries, this doubles. And the pandemic that have hit us and continue to hit us has worsened all possibility for mental health of the population and difficulties for access to mental health. And that has made that perhaps many pregnant women do not receive the proper care in this field. The risk important factors, it is extremely important to make a ask about the history. If depression has been present, the risk is much higher. And also to consider that our protection factors like a planned pregnancy, education, extremely important. You have emphasized that you go beyond high school, so this can work as a protective factor. And also the social support is extremely important. Sometimes that we forget or consider to be too simple is a sleep routine, extremely important. And you have insisted in a very clear way. Of course, this is going to have consequences upon the mother's health as well as the health of the newborn. And therefore, we need to be very alert to these type of situations. And the impact is going to be higher, as we saw before, in countries with lower income, with more malnutrition, more child abuse, and more infectious diseases. We also talked about treatment to balance risk-benefit, because there's this myth that while she's being pregnant, she shouldn't take any medication. But by far, we recognize that there's importance to use some drug when this is depression that's from moderate to severe. Always consider the interventions. Dr. Rondon, I think you have taught us the importance to recognize vulnerable women, to do a timely intervention, because the effect is going to be very important. We should try to prevent it, and don't forget that mental health is part of the comprehensive health and should be controlled during the prenatal care, and also when they control the child growth and development. Thank you very much, Dr. Rondon. We're going to have a short active pause so we can continue receiving questions, and then we're going to have that space. Just give us a couple of minutes, and we have our audience to relax. Rocco, we start with the active pause. We're not going to have simultaneous interpretation during the active pause.
Realizar una pausa activa para mantenernos saludables y también un poco ayudarnos a combatir el estrés, ¿no? Reducir esa fatiga laboral que a veces estar sentados mucho tiempo nos puede producir, ¿no? Y mantener que nuestros músculos estén flexibles, saludables, ¿no? Por favor, adelante con la pausa activa de Rob.
Buenos días, buenas tardes, desde cualquier parte del mundo, donde quiera que te encuentres, bienvenidos a realizar esta actividad saludable. Así que desde el Organismo Andino de Salud, Convenio Hipólito Unanue, los invitamos a participar en esta actividad divertida. Así que vas a tomar una hojita de papel, preferiblemente reciclado porque somos amigos del planeta, y vas a realizar una pelotica de papel. Pelotica de papel, vuélvela una pelotita de antiestrés. Y hoy vamos a trabajar esa liberación del estrés y la agilidad. ¿Cómo estás de agilidad? ¿Trajiste la habilidad del día de hoy? Bolivia, Chile, Colombia, Ecuador, Perú y Venezuela hoy trabajando juntos desde la agilidad para hacer esta actividad saludable. Así que nos fuimos. ¿Tienes tu pelotita antiestrés? Empiecen a lanzar, que toque el techo de donde estás. Vamos, láncela bien alto, arriba, arriba, arriba. Perfecto, domínelo. Cuando la tenga ya dominada, así que quiero que mire, lanzo, aplauso, recibo, lanzo, aplauso, recibo. ¡Nos fuimos! largo, grande, amplio, generoso y no se te olvide la sonrisa, eso es, lanzo, aplauso, recibo. ¿Qué tal si me regalas 2 aplausos? 1, 2, 2 aplausos, si se puede, 1, 2, domínalo, si se puede, 3 aplausos, perfecto, 1, 2, 3, 1, 2, 3, si se cae la pelotica la recoges y sigues, vamos, 3 aplausos. Vamos a romper el récord en el organismo andino de salud. ¿Cuántos aplausos eres capaz de dar? ¿Listo? Lanzo. Cuente. ¿Quién tiene el récord? Perfecto. 4, 5 aplausos. Lo que alcance a hacer. Esa es la actitud de energía positiva. Excelente. Vámonos, fuimos. ¿Cuántos aplausos fuiste capaz de hacer el día de hoy? El profe va como por 4 aplausos. Muy bien. Excelente. Lanza la pelotica. Con tus 2 manos te vas a tocar la cabeza. ¿Listo? Mire, lanzo, toco cabeza, agarro. Lanzo, toco cabeza. Con ambas manos. Perfecto, domínelo. Esa es la intención, esa es la actitud. Están demasiado coordinados y ágiles ustedes, así que cabeza a hombros, mire. Cabeza a hombros, agarro. Lanzo, cabeza a hombros. Coordínese. Si se puede. Agilidad. ¡Ánimo! Perfecto, necesito saber quiénes son los más coordinados del horas Conus. Si se puede, 3, 2, 1 y sabe que vamos a agregarle un tercer ejercicio. Yo creo en ustedes. Vamos a hacer cabeza, hombros, aplausos. ¿Listo? Lanzas la pelotica, cabeza, hombros, aplausos. No se rinda sin intentarlo, no fuimos. Cabeza, hombros, aplausos. Si se puede, cabeza, hombros, aplausos. Eso es. Domínenlo conmigo. Si se puede. Energía. Cabeza, hombros, aplausos. No se rinda. Rendirse es para otros, no para nosotros. Esa es la actitud. La gente del organismo andino de salud. La más fuerte, la más valiente. Esa es la actitud. Los que no se rinden. Eso. 3, 2, 1. Perfecto. Último. Cabeza, hombros, aplausos. Agárrenlo. Muy bien. Excelente. ¿Cómo estamos de coordinación y de descoordinación? ¿Vamos bien hasta ahí? Perfecto, lanzo la pelotita, voy a hacer un aplauso, pero lo voy a hacer detrás de la espalda y agarro, ¿listo? Entonces hay que hacer ágil, revisa tu espacio, que no te vayas a pegar con nadie, eso es, con nada. Muy bien, lanzo, aplauso atrás y agarro, si se puede, lanzo, aplauso atrás, agarro, vamos, energía, aplauso atrás y agarro, si se puede, lanzo, aplauso. Perfecto, domínenlo, regálenme 10 de esos movimientos, yo voy 5, ¿cuántos le quedan? 4, 3, 2, perfecto, 1, energía y descanso. ¿Qué tal si hacemos aplauso adelante y aplauso atrás? ¿Listo? Sí se puede, vamos. Voy llenándonos de energía hoy. Esa es la actitud. Entonces miren, lanzo, aplauso adelante y atrás. Adelante y atrás y agarro. Adelante y atrás y agarro. Sí se puede. Vamos. Energía positiva para todos. Perfecto. Adelante y atrás y agarro. Adelante y atrás y agarro. Sí se puede. Domínenlo. Esa es la actitud. Esa es la intención. Perfecto. Energía. 3. Muy bien. 2. Muy bien. 1. Último. Y agarrar la pelotica. Esa es la intención. Esa es la actitud. Bueno, me dicen que Bolivia, Chile, Colombia, Ecuador, Perú, Venezuela trabajan juntos desde la coordinación hoy para llevar hábitos de vida saludable. Muy importante. No hay que rendirnos, ¿cierto? A veces parece difícil, pero no lo es si le ponemos actitud. Último ejercicio. Vamos a hacer el último. Quiero que tomes tu pelotica. Mire lo que vamos a hacer. Con ambas manos. La vas a acercar a tu cuerpo. Vas a soltar la pelotica. Le vas a dar un rodillazo. Perfecto. Y la pelotica va al aire y la coges. Uy, profe, eso suena muy difícil. Realmente suena más difícil de lo que en verdad es. Usted lanza y agarra. ¿La tiene? Perfecto, mire. Perfecto. Que rebote. Que no se caiga. Si se cae la recogemos. No pasa nada. Eso es. Rebota en la rodilla y la agarras. Si se puede. Muy bien. Cuando domines la pierna derecha, quiero que lo intentes con la pierna izquierda. ¿Listo? Si se puede. Vamos. Coordinados. Si se puede. La otra piernita ya. Muy bien. Suelto. Perfecto. Rodillita y la agarro. Ahí les vamos dejando ese ejercicio de tarea a todas las personas del Horas Cono para que trabajen la coordinación, la agilidad, muy bien, el dinamismo, 3, muy bien, 2, excelente, 1, Perfecto, y descanse, muy bien, excelente. ¿Cómo nos ha ido el día de hoy? Como siempre, un estiramiento para liberar las tensiones de nuestro cuerpo, llenarnos de energía. Quiero que cojas la pelotita con ambas manos, perfecto. Sube los brazos todo lo que puedas, separa las piernas, estírate, estírate arriba. Eso es, sonrisa. Mire, nos inclinamos para un lado, estiramos la espalda, perfecto, liberamos estrés, tensiones acumuladas, nos llenamos de energía positiva, vuelves al centro lo más arriba que puedas, vamos para el lado contrario, eso es, y respirando siempre. Respiración, algo súper importante. Estiro, 3, 2, 1, vuelvo al centro, tomo aire, exhalo y bajo los brazos, calorcito, energía, fuerza. Mire, hoy desde el Horas Cono les agradecemos de todo corazón haber estado con nosotros en esta pausa activa, saludable, divertida, y los animamos a seguir haciendo ejercicio de forma activa. Organismo Andino de Salud, Convenio Hipólito Unanue, un abrazo para todos, chao chao.
Muchas gracias por participar de
Thank
este
you.
breve espacio. Y
This space.
antes de
And
ingresar
before
ya en el
going
periodo al
into
espacio de las
the
preguntas,
Q&A
no queremos dejar de pasar nuestro
sections, we
agradecimiento
would
a
like
los que están
to
conectados desde
express our
Argentina,
gratitude to those connected
Colombia,
from Argentina,
Bolivia,
Bolivia, Chile,
Ecuador,
Colombia,
España,
Ecuador,
Guatemala,
Spain,
México,
Guatemala,
Perú y
Mexico,
Venezuela.
Peru, and Venezuela.
Asimismo, de las instituciones
Also, the
que
institutions
saludan en el chat,
that greet
empezando
us
por los Ministerios de
through
Salud de
chat,
Bolivia, Chile,
the
Colombia,
Ministry
Ecuador,
of Health
Perú y
of Bolivia,
Venezuela,
Chile,
la
Colombia, Ecuador,
Universidad Nacional de
Venezuela,
Cajamarca,
Cajamarca
Perú, el
National
INTA del Perú
University
de
in Peru,
Salud, el
the
Hospital
National
Nacional
Institute of Health from
Loaiza, la
Peru,
Cruz Roja Peruana,
Loaiza
el
Hospital,
Hospital
Peruvian Red Cross,
Regional Lima, el
Ica
Hospital
Regional
Regional
Hospital,
de Callao, Luis
Lima
Pasteur,
Norte
el Centro
Hospital,
de Salud Mental Comunitario Villa El Salvador, el
Community
Hospital
Mental
General
Health
de
of
la
Villa El
Clínica
Salvador,
Juan Pablo
and Mother
II
and
Villa El
Child,
Salvador,
Villa El
y la
Salvador
Clínica de Medicina Familiar
Hospital,
Dr. Ignacio Chávez de México.
Ignacio Chavez,
Agradecemos a
Mexico
todos
Family
aquellos
Hospital.
que nos siguen
We
acompañando
thank
en
all
este
those
webinar de
follow us
una
in
semana
this
más.
webinar week of week.
Muchísimas gracias a
Thank you
todos.
very much
Doctora
to all
Marta,
of
por favor,
you.
le vamos a
To
pedir
Marta,
que prenda su
could
cámara.
you
Hemos logrado
please
recopilar algunos
start your video? And
bueno, hay
we
preguntas,
have
vamos a tratar
many questions.
de
We
reunirlas,
are going
considerarlas
to
para
try
poder
to
ir respondiéndolas y
summarize them.
aprovechar de su presencia, doctora. A ver,
Let's see.
empezamos. A ver,
We
vamos
start with
sí. Nuestra sociedad tiende a ejercer
our
mayor presión
society
sobre el
tends
rol de
to
las madres.
put more pressure on the
En un webinar
mother's
sábado
role.
pasado en el Horas Cono se mencionaba que las
In
madres
Horas Cono, it
con
was
dependencia de
mentioned
alcohol
that mothers with
buscan
alcohol
atención
dependency don't seek
por el
for
temor de
attention
perder la potestad de
because they're
decidir,
afraid to lose the
generando
control of their
así
children,
problemas de un subregistro.
the custody of the
Se
children. And
podría
that
considerar una
we
hipótesis que
consider
relacione de manera
an
similar
hypothesis that would relate
la
in a
presión
similar
sobre los
fashion
roles de género
social pressure or
en el
gender roles
diagnóstico de problemas
in
de
the
salud mental
under
en las
registration
pacientes
of mental
embarazadas.
health in pregnant women and postpartum women.
Recomendaría para
If that
reducir
is the
el
case, what will you
stigma de la
reduce?
maternidad
What would you recommend to reduce that stigma? Go ahead,
por
doctor.
favor?
Es una pregunta, muchas gracias,
This is
muy
this
compleja.
is a very complex question.
El alcoholismo en las mujeres y el
Alcohol
estigma
consumption in women
que marca
and
a
the
las personas
stigma
que sufren de salud mental
that
y
suffer mental
las
health
consecuencias
and the
desfavorables que pueden
favorable
tener en términos
consequences
de
that they
que
may
sus
have in
derechos
terms that
sean
their rights
respetados.
could be not
En primer lugar, me gustaría
disrespected.
decir que el
In first place, I
alcoholismo
would like to say that
está
alcoholism in women
estrechamente
is
relacionado
closely
con las
linked
experiencias de violencia.
to violence
Una mujer
experiences. That
que
is a
desafortunadamente
woman
toma
that
alcohol,
is
bueno,
drinking
lo
more than
primero que tenemos que
adequate.
buscar
The
es
first thing we need to find
quién
out
la está
is
violentando, quién la ha
who is
violentado de una
generating
manera muy
violence or
violenta.
doing
Y
some
ahí
trauma in
hay
their life,
espacio para
and
nuestra
there is
intervención.
space for intervention.
El otro tema que ha mencionado
The other
es la
topic you mentioned
glorificación de la maternidad.
is the glorification
Es culturalmente
of maternity, which is
una de las
culturally
de los lastres que cargamos
one
en la
of
sociedad.
the issues that we still carry in our society, because at the same time that you glorify maternity, we try to repress or neglect the use of women's sexuality. So this is quite a complex subject, and because we are a country that is Marianist, the women need to be like a deformation of the Virgin Mary, and that they need to suffer, and that are morally superior to men. This is a utopia, it's a distorted utopia of the figure of the Virgin Mary, and it has historical roots. But once we consider that this is occurring here, there's a lot of things that we need to combat. Women are human beings. They can become perfect but full of defects. To become a mother doesn't convert you in a human being that's better or worse than you used to be before. You can still have room for improvement and perfection. So we should not be afraid that admit that we need help. It doesn't make us less valuable. The contrary, talks about our self-criticism, and the problem with prenatal depression and postpartum depression, not that women hide it, is because we don't ask. So the responsibility is in the health system of learning how to ask. The same way as we ask of the number of daily stools, we need to learn how to ask the respect. In the last month, have you felt tired? Things that used to interest you are still of your interest, or you think you don't want to read the newspaper? Do you feel sad during the day? Tell me, where does that sadness coming from? It's easy, but we need to do it. The other thing that we need to remember is that regardless of the prejudice that we have, because we are women and we think that we need to be perfect, because if we are not perfect, we're going to be sanctioned. We need to remember that the law is on our side. We have the Convention of the Protection of People with Disability, where it clearly states that women with disability, in particular girls and women, have to have the same rights as men. So if you have a mental condition, they cannot neglect maternity, they cannot neglect the right to get married or the custody unless you demonstrate that you are generating violence or you are completely, or you're exploiting your child sexually. So we need to support each other and use the legislation that protects us in this case. And we need to remember constantly that men and women are human beings with failures but potential. Thank you, doctor. We continue with more questions. The pandemic was a period of highly stress for pregnant women, especially in the first months. What care, in addition to normal control, should be prioritized for those infants who were found inside the uterus in the early 2020? Well, that's a very nice question. Many of these children had mothers that were confined in the heart of protective families. They will have an advantage. But there are other more, perhaps more, that were in a womb of a woman who had no access to prenatal control other than phone call, which is not adequate. That if they had an emergency, they didn't know where to go, or had to go through the police control and explain everyone why they were on the street. They didn't know because the scientific community didn't know that at that time it was a new disease. It was a vertical transmission or not. And when the vaccine came, and there were controversy that if the vaccine could be used in pregnant women or it was harmful for the fetus. We have solved all those questions, and the answers has been reassuring. But those who lived through those uncertain times were had many anxiety generated, and the fetus was exposed to higher levels of cortisol. So it is possible, this is a hypothesis, that these children are more anxious, more impulsive. So we need to remember that we need to learn how to regulate their affection, more patience, teaching them to control their impulses, be there to take care of them with this old story that let him cry because that's good for their lungs, which is not true. So to regulate the affection, and when they start going to school, be more alert to see if there are higher levels of aggressiveness with other children. It's been a difficult period. Anxiety increased significantly following the studies of Minsk and other countries during the first year, but in 2022, the levels of anxiety had decreased significantly. So we also need to get credit as a species that we were able to adapt on one hand, and on the other hand, we have found, thanks to the scientists, we got results of important answers. There was no vertical transmission, that the vaccine was safe for the fetus. So that may have also brought calmness to those who were pregnant during the 2020 and 2021. Thank you. We have guidelines of other resources available for the training of the evaluation of mental health of pregnant for the health personnel? Yes, they do. We have the guide from the prenatal, from the Ministry of Health, that tells us how we evaluate the emotional state of women during prenatal control. In general, all the institutions and ministries of health throughout the world who publish global guidelines, for example, like the NICE Institute of England, tells us about the need of making two major questions. During the last month, have you felt was more fatigue or tiredness, or during the last month, have you lost interest or feel pleasure in things you used to like? And the answer of yes to any of these questions should invite us to use a scale, for example, the Edinburgh scale or PHQ, that are available everywhere, that have been validated in Spanish, to decide if there is depression or not, and you can do the proper transfer. Thank you. And to conclude, two more questions to conclude. What opportunities are offered by telehealth for prevention and treatment of health issues in women throughout their life? Through mental health services, what challenges do we still have for the effective use of these services? The telehealth services have demonstrated to be very useful in mental health. Among us, we don't have remote care. It's sad that we closed that was working. There must have been a way of adding this based on the evidence of what worked and what didn't work. But general in other areas, for example, there are reminders of doing exercise or recalls a text message to remind you to take your medication. There are scales that can be used in the phone that will show the level that you are at that moment, and at the same time is being transferred to the member of the team who is following that patient. Those are one of the uses. We're also being used to decide if you need to make a claim or a report of a violence issue, and it they tell you about the risk that you are having with this partner, for example, that's acting violent against you, and they show the alternatives that you can use. In Canada, they're doing a lot of work in this area with a lot of success, and these are experiences that perhaps we could add ourselves. And psychiatry and psychology can do virtual consultations because we don't have to do any physical examination. The mental exam is a specialized conversation. So it can do adequately with psychiatry and psychology, remembering that the people with anxiety can communicate better when they are not on site. That it has been shown in some schools where children with attention deficit disorder and anxious disorder have felt better in virtual school than the general population. And then the final question. At the community level, what strategies would you recommend from the scientific evidence to promote mental health in pregnant women? Promotion of mental health in pregnancy has to occur before pregnancy. First, to avoid exposure to trauma, in particular, the violence. In our country, we have, and in the Andean region, very high figures of sexual violence against children, girls, boys, and adolescents. This needs to be eradicated because sexual abuse in early stages of life causes irreversible changes in the brain and therefore in mental health of those affected. And as we have seen, this is a factor that predisposes to suicide ideation during pregnancy and depression and anxiety during pregnancy. So this is a promotion measure for mental health of the pregnant women. And other things that are more in our reach, perhaps, is pregnancy planning. And this goes through comprehensive health education, but also through a contraception policy that is adequate, based on evidence, and well implemented. We have made major steps in progress that perhaps the staff doesn't know. Perhaps the adolescent can receive contraceptive without the presence of a parent or a tutor. And this is a major advance for adolescents. We cannot close our eyes and think that they're adolescents because we tell them take good care and prevent any pregnancy. She's going to stop having sexual intercourse and not get pregnant. The best way to avoid pregnancy is by use contraceptives. So in order to have planned pregnancies, which is a protective factor for depression in the postpartum and prenatal period, we need to have an adequate policy for contraception that works. Thank you, Dr. Rondon. And to close this space of Q&A, I'm going to ask you to, in 1 minute, give us a final message before thanking all of those who have sent questions. Difficult to respond all of them, but we always consider them to future meetings and define the topics. Go ahead, Dr. Rondon, for your final message. Pregnancy and rearing children or upbringing children provide growth of women who go through this experience, but are not free of stress and are not free of
los
emotional
trastornos mentales.
disorders and mental
Si no
disorders.
estamos disfrutando
So
esa
if we are
etapa,
not
tenemos
enjoying
que
this
contárselo
stage,
a alguien
we need to tell
para poder
someone
encontrar
in order
alivio
to find
y poder
relief
volver a disfrutar
and go
de
and
algo
to
que
enjoy
es
of
en
something
principio muy
which is
positivo,
essentially very
pero
positive,
que tiene
but
sus bemoles.
has their limitations.
Muchísimas gracias, doctora
Thank you very
Presidente
much, Dr. Rondon, once again,
por su brillante
for your
presentación
brilliant
y la
presentation
paciencia
and the
en respondernos
patience
todas las
in
preguntas
responding all
con
of our
claridad.
questions
También agradecemos a
with
todos
clarity.
los
We also thank
participantes, al
all
equipo de
the
Horas Conio
participants, the
y a
Horas
todas las
Conio
personas
team,
que han
and to all the
participado en esta
people who
actividad.
participate
Y
in
a
this
esto posible
activity,
gracias al
which has
compromiso
been possible
con
thanks to the commitment with the Andean and Latin American
indudablemente ha
integration.
sido un tema importante.
Undoubtedly, this has been a very important topic,
Enfoquemos en esta
and
ocasión la salud mental,
in
el
this
binomio
occasion,
madre-niño,
we talk about the mental
y la
health of
importancia de
the
la familia y poder
mother and
vivir en
child
sociedad,
team,
y que
and
definitivamente tenemos que tenerlo
we
como
need
una línea
to
prioritaria
have it
en
as a
nuestra,
priority line
en
in
nuestro
public
país y
health
para
of
la
our
salud
country
mundial.
and through the entire region.
En ese sentido, reiteramos el
In that regard,
agradecimiento
we
por
reiterate
su
thanks
participación y la
for your
atención de todos
participation and all
en nuestra audiencia
our
y no queremos cerrar
audience.
sin antes
We would
invitarlos
not like
que
to
la
close to invite
próximo
you.
jueves
The next
nos podemos
Thursday,
acostumbrar a
we have
reunir el
our meeting
webinar, que es
webinar, which is
el
the
próximo día con el tema,
with the topic.
déjeme ver por favor, que
Let me
no lo
check.
tengo acá, con el tema de niñas, adolescentes y
Girls,
mujeres en la
adolescents,
ciencia,
and women in science.
agentes innovadoras para el desarrollo
Innovative
sostenible
agents
y
for
la reducción
sustainable
de gases.
development and
Los
reduction of
esperamos
gaps.
el próximo
We
jueves a
will
la
see
misma
you
hora.
next
Muchísimas
Thursday
gracias.
at the same time.
Hasta
Thank you
luego.
very much. See you soon.
Muchas gracias, hasta luego.
Thank you.